Hello everyone, welcome back to Karan Academy. My name is Karan and today we'll be kicking off our lecture series on the respiratory system with asthma. So let's start off with the definition. So what is asthma? So obviously this is a chronic inflammatory condition affecting the respiratory system, but the three main features that make asthma are as follows. So there's something called bronchial hyperresponsiveness with reversible airway obstruction, the focus of this being the reversible component. And we'll talk a bit about why this is important in a second. And thirdly, they also have increased mucus production. Now, it's important to know that when we talk about asthma, I'm sure many of you have heard about your friends' asthma or your own asthma often getting worse with certain triggers like pollen, dust, certain animals, and so forth. When we talk about certain triggers, it's often good to think, are we thinking of asthma as being allergenic or non-allergenic? Because broadly, there are two types of asthma. In terms of risk factors, I'm sure you've heard of the atopic triad, which is a family history that puts people at increased risk of these atopic conditions. This triad includes asthma, atopic dermatitis or eczema, and allergic rhinitis or hay fever. So when you ever suspect any one of these conditions, it's always good to ask about the other two and whether there's a family history of any of them. Yep. It's also, especially during first consultations, to ask about whether there are any environmental triggers that they might have noticed coinciding with the severity of their symptoms. Have their symptoms been worse with higher pollen levels? Have they been out more? Have they recently moved house with the potential of mold? Are there any pets in the house, any dogs or cats that they may be allergic to? Or are there any occupational triggers like baker's asthma, often associated with flour dust? In addition to these allergic symptoms, you may also have non-allergic asthma, which is typically harder to pick up on because it doesn't usually fit in with our typical picture. So it's always good to ask if they've been sick recently with any viral infections and whether this might be irritant induced. So factors like secondhand smoke, certain environmental triggers can all irritate the airway and mimic the features of what seems like an allergic asthma response. You can also have things like GORD. And with GORD, obviously, if you have reflux, that can seep in some partly into the respiratory tract and cause a level of inflammation. And that hyperresponsiveness can mimic, again, the symptoms, the signs and symptoms of typical asthma. Going back to a very baseline level of what's going on, well, that raised the question, well, why do these people have asthma? And it's a question that you will be asked time and time again by parents, and rightly so, because they might be very confused as to, well, I don't have asthma. No one in my family does. Why does little Timmy here have asthma? And so it's, I think, a response that you should be well prepared for and be able to answer. As with many often inherited and inflammatory conditions, it's good to explain that asthma is basically a multifocal disease. What we mean by this is that part of the reason they have asthma is because of a genetic predisposition, but that's not the entire picture. Just because someone is genetically predisposed doesn't necessarily mean that they will develop asthma. The reason or the basic premise behind the genetic predisposition is that of a T helper cell hyperactivity. Now, your T helper cells play a very unique role in the respiratory tract because this is often a common site for many infections and pathogens to come in. Your T helper cells often respond to them by releasing interleukins, cytokines, and many other chemicals to neutralize these pathogens. However, as you can imagine, if you have a hyperactivity with these cells, that can often result in a response that's way out of bounds with what it should be. In addition to having the genetic predisposition, it often takes an environmental trigger to set off that inflammatory cascade. So there might have been something else that's happened, or a new environment, or a particular pollen pathogen, something has happened that set off that trigger. Talking a bit about what is actually going on with the bronchial hyperresponsiveness and the inflammation. So, well, why do they have inflammation? Going back to what we talked about with the T helper cells or the T2 helper cells, once you have the inhalation of the antigen, which, as I mentioned, can be anything from pollen, mold, animal exposures, and so forth. Remember, this is the allergic type, right? Because we have an immune mediated process. They inhale the antigen. You then have high levels of cytokines and interleukins being produced by your T helper cells, which then go on and recruit eosinophils and mast cells, and this triggers the inflammatory cascade. That cascade itself causes the muscles in the bronchi to constrict, right? Because if you, the way I like to think about it is, let's say if there's something going into your airways that it shouldn't, your body's natural response is going to be to try and close off that airway to minimize whatever's going in. So it kind of makes sense in terms of a survival mechanism. So you get the constriction of the bronchial muscles, and then you also get obviously the inflammation that's happening because you've released all these cytokines and mast cells. The last component is the endobronchial obstruction, and this is what causes most symptoms with our patients. The main symptom that they will talk to you about is, doc, I'm having shortness of breath. I'm having trouble breathing. It's really hard to breathe. I feel tightness in my chest. The primary reason that's happening is because they actually have an obstruction in the lumen of their bronchi. And that is because of a few reasons. Firstly, as I mentioned, the bronchi are constricting because of that inflammation. Secondly, you now have increased mucus production, because what mucus basically does is it traps in a lot of those antigens and pathogens. Thirdly, you have a lot of edema because you now have a lot of inflammation going on. And as you know, inflammation goes hand in hand with edema. Lastly, over time, if your smooth muscles in your bronchi keep constricting time and time again, you're going to end up with a hypertrophic picture where even if you don't have an antigen triggering off a response, you will still end up with some degree of endobronchial obstruction. So those four factors together contribute to endobronchial obstruction, which is the primary reason patients come in with symptoms. The next thing I'd like to talk to you a bit about is signs and symptoms. Now, I'm sure you guys are very familiar with how asthma presents, and this is very commonly a history-taking station. So I think this is something you should know in and out. But in addition to just asking about the symptoms of asthma, which I'm sure you'll do, if you really want to go above and beyond, I think these are the four domains you really need to take off during the actual history taking. The first thing is always going to be obviously to actually assess, well, is this patient or does this patient have asthma, or is this asthma? And a good way to talk about that is obviously going back to the signs and symptoms. Do they have shortness of breath? Do they have a cough, tightness, a wheeze? Do they have a diagnosis of asthma? That's often a very good question to ask from the get-go. Have they had any recent attacks, family histories, atopic triads, all that? The second part is that once we establish that, well, I really do think this is asthma, you want to ask yourself, how bad is it? How aggressive do I want to go with their management? How worried am I about this patient? So you want to ask, how often do they have their symptoms? Do they have any nighttime symptoms, which are a big factor to consider? Do they have symptoms at rest? Again, a big red flag. For people who have already been started on a medication, you want to ask, how often are they using their reliever medications or their Ventolin? Their exercise tolerance is a good one, especially for young kids. You want them to be able to play around and do the things they want without their disease affecting them significantly. So can they do that? Going on that very note, what is the impact on school? Do they have to miss school? Do they have disturbed sleep? And how's their general life? And then lastly, and this is really good to stratify risk, have they ever required hospitalization for an attack? Have they ever required to be sent to an ICU for their attack? Because if they have, that tells you that this person is at a super high risk of decompensating really quickly if they have an attack. Therefore, you would start them on a relatively higher level of basic medications, and you'd also warn them about, well, this might happen again, and set up an action plan. And that's really important. And we'll get on to an asthma action plan in a second. Thirdly, we want to ask ourselves, what's causing their asthma, right? Just knowing that it's asthma doesn't really help us, because they may have a very specific trigger that's unique to that individual and that situation. So we want to ask ourselves, does this person have hay fever or eczema? a good way to think about this is also ask yourself, does this seem to be an allergic type of asthma or a non-allergic irritant type of asthma? Do they have any pets, any food allergies? Are they particularly exposed to things like pollen, dust? Does anyone in the family smoke is another good one to ask. And then lastly, education. And this really, when you start asking these questions, your examiner really can tell that you've thought this through and you're really attacking the issue from all fronts and developing a holistic approach to the issue. So does the patient have an asthma action plan? Every patient with asthma should have a plan. Do they know what to do if they have an attack, right? I'm sure many of you, at least in Melbourne, would have heard of the thunderstorm asthma-related incidents, and this can often happen. So do you know what to do if things go wrong, right? Lastly, we want to also assess their adherence to medication. As you know, many of the people taking medications aren't often super good at them. So we want to ask them, are they taking it well? Especially if they come in telling you that their symptoms are still persistent despite you increasing or changing medications. It would be very fair of you to ask if they could demonstrate their technique to you, because that's often an area they lack in. And just make sure that they're taking the right medications at the right time. If you have time, I think it's also prudent to it's also relevant to ask about a few side effects that we know are commonly seen with certain puff of medications. Do they have any oral thrush that's common with inhaled corticosteroids? Do they have any tachycardias or palpitations because of beta agonists, or any jitters? Because as we know, SABAs and LABAs can both cause beta adrenergic symptoms. In addition to those, when a patient comes to you in ED, as an intern, the first thing you want to rule out is a life-threatening asthma exacerbation. So here we have features fitting in with each severity score. And if you see or observe any of these, that tells you that things are not going all that well for that patient, and you need senior help and you need to act quick and aggressively. So obviously, if they're desaturating, a silent chest is a huge factor. So as part of your respiratory exam, you know that wheeze is quite typical of asthma. However, if you don't hear a wheeze, or even worse, if you don't hear anything, that actually is a red flag. So don't be reassured by the silent chest. If they're agitated, if they're tired, if they're cyanotic, obviously, and a good way to assess that is how much can they speak? So can they speak in full sentences? Is it just words? Is it just phrases? Are they out of breath? In terms of investigations and diagnosing asthma, to make a formal diagnosis, you often need to do spirometry or pulmonary function testing. It's important to know that you can only do this beyond the age of 6, because this requires patients to blow and follow instructions, and this is often hard to do in very young kids. The diagnostic criteria for asthma is you need to have an FEV1 by FVC ratio of less than 70%, and you need to have a post-bronchodilator increase of 12% or 200 ml in either FEV1 or FVC. Now, what does that mean, right? The way spirometry works is you are asked to take a deep breath in and then blow all of it out as fast as you can. FEV1 is the amount of air you can blow out in the first second, or the forced expiratory volume in the first second. And FVC stands for forced vital capacity, which is how much air you can blow out in total. Because asthma causes basically constriction of the bronchi, you aren't able to blow out a lot of air really quickly, which is why you have a reduction in the ratio. What often this means is that the FVC is fine because your lungs are unaffected, but the airways or the tubing system is affected, which is why it's going to take you relatively longer to get the same amount of air out, which is why the FEV1 is often affected. Now, if you go back to what we said about the features of asthma, the first thing or the second thing I mentioned was that it's a reversible condition, right? Which means that they should respond to a bronchodilator. A bronchodilator in this case would be something like fentanyl or a short-acting beta agonist. And the threshold we use is that they should have an increase of 12% or 200 ml in either the FEV1 or the FVC. If you do not see this response, it usually means that the obstruction is non-reversible. And that is quite typical of a condition called COPD, or chronic obstructive pulmonary disorder. I mentioned that you can only perform this test in children aged above the age of 6. And that raises the question, well, if the kid is less than 6 years old, what would you do? It's tricky, but what is often done is you might provide them with Ventanyl and ask them to take it and see if the symptoms improve. Basically perform a trial. If the symptoms do improve, you can make a preliminary diagnosis of asthma, awaiting further testing when they do turn 6. But if there's a poor response, it often tends to be non-asthma related. It can often be a post-viral wheeze, and many asthma-like conditions that kids have at a very young age tend to resolve, or they tend to grow out of it, which is reassuring. You can also use a methacholine challenge test that's often second line. And what basically happens is we try to almost mimic whatever is happening with an asthma attack. And so a positive test result would be if you have a reduction in the FEV1 by 20%. Lastly, we can also do a chest X-ray, and a chest X-ray isn't really useful for making the diagnosis itself, but can tell us a bit about the severity of it, or help us assess for, well, is there anything else going on, like a pneumonia or pleural effusion? But also you do see certain changes with severe asthma that can be quite obvious on a chest X-ray. These include lung hyperinflation, a low flattened diaphragm, and intercostal spaces. As you can see here, if you count the number of anterior ribs, which you should usually be able to count about 8 to 9, you can have 1, 2, 3, 4, 5, 6, 7, 8. It's way beyond that, right? And going back here as well. And this is quite typical of asthma. So yeah, they should usually be about 5 to 6, but here obviously you have way more than that. You can also see flattening of the diaphragm and wide intercostal spaces. The reason this happens is as the kid is trying to breathe out or breathe in as much as they can, it's often a reactive mechanism of the lungs to hyperinflate to make up for that hypoperfusion. In terms of management, you need to know what you are aiming for. So even before we jump in and talk about any medications, you need to ask yourself, well, what would be considered good management? Obviously, in an ideal world, no symptoms would be our standard, but realistically, that's often not very feasible. So what we usually aim for is minimal daytime symptoms. We want no nocturnal symptoms with no restrictions on physical activity. We also want them to be using their SABA as little as possible. And anything that's more than 2 times a week is usually considered to be suboptimal. In terms of what the actual medications are, for short-term exacerbations, we use a reliever. Then we move on to preventers, which include inhaled corticosteroids, long-acting beta agonists, and we can often use a combination of them. So starting off with the SABA, in terms of preventers, and you'll hear about preventers with both asthma and COPD, the 3 main medications we use include inhaled corticosteroids, long-acting beta agonists, and you can also have long-acting muscarinic antagonists, so LAMAs. A common question is, well, what do I use in which one? And a good way I like to think about it is if you arrange them in the order of ICS, LABA, LAMA. For asthma, you go ICS towards LAMA. For COPD, you go LAMA towards ICS. So let me just reiterate that. For asthma, you'd start them on ICS, then move them to an ICS plus LABA, and then move them on to ICS plus LABA plus LAMA. For COPD, it's the other way around. So you often start off with a LAMA, then the LABA, and then might consider adding on an ICS. So the reason we do that is because the basic mechanisms of both of them are quite different. With asthma, we have a reversible condition that's more hypersensitivity and less chronic change. With COPD, we have more chronic change, less acute hypersensitivity that can be resolved. And here's the same thing visualized. So All patients would need to have their risk assessed and carry a reliever, which is going to be their SABA. Most patients are going to require some form of maintenance ICS, which is going to be low dose. You can then move them on to an ICS-LABA combination. It's also good to know that for asthma, you would never, ever, ever use a LABA without an ICS. That's just never done, and it's been shown to contribute to a higher risk of death. Lastly, you can move on to ICS plus LABA, LAMA, but at that point, you'd like to often consult a specialist because this is obviously poorly controlled asthma. There are also leukotriene inhibitors, which are a new class of medications, which can also be used. Lastly, when we talk about asthma, obviously acute exacerbations are going to be an important factor in the ED. So whenever a patient comes in with asthma, going back to that assessment we talked about, you want to assess how bad it is. And a very good scale to do that is the Mohs assessment scale. It's an acronym that stands for mental state, oxygen saturation, work of breathing, and speech. And that is obviously going to be, so the mental state, they can either be distressed or drowsy. Oxygen saturations can be the normal or starting to desaturate. Work of breathing is typically going to be increased in all forms, but with critical, you can often have no work of breathing, which is going to be a huge red flag. And then speech, again, as I mentioned earlier, how can they actually speak? Can they speak in full sentences, words, or are they completely silent? When we talk about the actual management, oh shit me is an acronym that can be used to think about how you'd manage asthma, which is also how you should feel if a kid with asthma comes in with a silent chest. And it stands for oxygen, salbutamol, which you'd give in a burst therapy regimen, which includes a lot of doses, quite one after the other. You can also use hydrocortisone, and that's often given IV, or prednisolone orally. You then also give ipratropium bromide, theophylline, magnesium sulfate, and escalate care. And this is usually the hierarchy you'd go with. This is more so fourth-year content than third-year content, but you would always, always, always start with oxygen, salbutamol, oxygen, especially if they're desaturated. You'll always give them SABAs. You might give them, you almost always give them prednisolone orally. You can give them hydrocortisone if they are unable to take anything orally. However, more invasive tools like theophylline, magnesium sulfate are often reserved for patients who do not respond to initial therapy. And that's all the content we had for asthma. Thank you all for coming. As always, if you have any questions, I'm more than happy to answer them either on my email or through Facebook. And as always, please take care of yourself and look after yourself and look after your loved ones.